Okay. So we're gonna hit reality therapy actually fairly quickly here today. I'm also going to try to add group psychotherapy here in the next couple of days, and then I will probably post the other PowerPoints. I haven't decided absolutely yet, but I think I may post the other PowerPoints and ask you to study those, but I probably won't add a full lecture to those. I have to decide. I haven't figured that out yet. So we're down to the last several lectures and PowerPoints here for the semester, as weird as this is. All right, I'm going to jump right in. We're going to try to move through this fairly quickly today. So reality therapy is a type of cognitive behavioral therapy that essentially is focused on shaping and improving motivation in the hopes of changing a person's behavioral choices. And the idea here being that Glasser, the guy that developed reality therapy, argued very forcefully and actually fairly convincingly that if you can get people to modify some fairly basic behaviors, you can significantly change the course of their lives. This is not a deeply insight-oriented sort of psychotherapy. It's very pragmatic, fairly directive, and fairly easy to implement with people who perhaps traditionally are not the best psychotherapy candidates, people for whom motivation really is the issue. Motivation to behave in certain ways that will serve their best interest. So you find this approach to psychotherapy being used in settings where you'll often have those kind of patients. School settings with adolescent patients, corrections, prison settings, and social work settings where where social workers and counselors are working with people who are sometimes poorly or minimally motivated for change. So basically, what Glasser is arguing, as I said, fairly convincingly, is that our fundamental happiness or unhappiness, the course of our lives, is largely determined by our behavior. And we know that there's some legitimacy to this, right? You know, I probably have talked to you before about I think they call it the success sequence, and basically it's the finding that if people engage in certain fairly straightforward, achievable behaviors in a particular order, their likelihood of falling below the poverty line of income is virtually zero. And basically what this success sequence is: graduate from high school, get a full-time job, and get married and stay married before you have children. Graduate from high school, get and keep a full-time job, get married and stay married before you have children. And what they have found is that the people who have these behaviors in that order are almost never impoverished. And of course, we know poverty is correlated with all sorts of problems, both emotional problems, higher levels of unhappiness and that sort of thing, higher levels of substance abuse, addiction, dependence, higher rates of death from most sources, et cetera, et cetera. Well, you can shape that in a person's life. You can change the very course of their lives by ensuring graduation from high school, securing a full-time job and keeping it, and then not having children unless you're already married and then you stay married. So good example of kind of what he's talking about. If we can help people choose healthy behaviors and implement them, it will change their lives in fairly significantly powerful ways. He also makes the assertion, and this is an integral part of the therapy, that and you spend a little bit of time working with the patients to help convince them, to help them recognize that all behavior is motivated and purposeful, and that we choose most of our behavior. Now, there are some exceptions. You don't choose for your heart to beat. You don't choose for, I don't know, if a person who has epilepsy doesn't choose to have seizures. And those are behaviors. Your heart beating is a behavior. Your having a seizure is a behavior. But the reality is that most things that we do, we choose. Sometimes you could say in psychodynamic language, preconsciously. Sometimes you could say in cognitive behavioral language, we choose things as the result of erroneous automatic thoughts, problematic schemas that we may not even realize are there. But nevertheless, while we may not be aware of what's driving the behavioral choices, we are making the behavioral choices generally voluntarily. Glasser makes the point that these choices that we make can be understood, you can break them down as being motivated by, well, first by some fairly basic physiological needs. These are the drive kinds of things: hunger, thirst, safety, these kinds of things. But they are also motivated by 4 psychological needs that he identified. He named the need for belonging, affection, love, the need for power, the need for autonomy or independence, and then one of the things I like about Glasser is he recognizes that fun is actually a psychological need. You don't often hear that talked about in the field, but he makes reference to the fact that is definitely a factor motivating behavior. And then he makes the observation that there's a reason why, as I list out these 4 psychological needs, and as they're indicated there on the PowerPoint, the number 1 need listed is love or belongingness, connectedness. And he makes the point that this is the most influential need simply because all of the other needs derive from the connectedness that is established by a sense of belonging, affection, love, this sort of thing. So you got this idea that you have these 4 psychological needs that are driving, that are motivating behavior. And then Glasser makes the point that there are some other basic ideas that you need to have a handle on in order to begin to implement reality therapy. The concepts of the perceived world, the quality world, what he calls the comparing place, and what he calls total behavior. These are actually fairly straightforward, simple ideas that he assigns unusual vocabulary to. So Glasser's perceived world is essentially our subjective experience. It's essentially his acknowledgement that we're not seeing the world as it is in reality. We're seeing it colored by our schemas and psychoanalytic language, by the transference, by our prejudices, past experience, by our very biology, right? The result of all of this is that the subjective experience, the perceived world, is to some degree inaccurate, and importantly, it's malleable. It does change as input, as circumstances, as the environment that shapes us changes. Our perceptions, the perceived world, alters. And this is important because Glasser is making the argument that this opens up the possibility that we can choose to change how we perceive our circumstances. All right? So the perceived world we have some degree of control over, or at least some influence over, our subjective experience of the world. We can put some effort into making changes there. The quality world is essentially those aspects of the perceived world that we have cathected. Cathected being an old psychoanalytic term for the investment of emotional energy. So basically what we're talking about here is that the quality world is the part of the perceived world that we are assigning value to, paying particular attention to. It's the part of our perceived world that is the most important to us. It's the things in our perceived world that are important to us. And those particular things that are so important, he calls the personal picture album. And these are things that are basically, they meet one of the 5 basic needs, physiological, or one of the 4 psychological needs. They're changeable because obviously those things, the things that we're valuing are going to change as we mature and grow, as our circumstances change, depending on how we feel that day. Obviously if you're ill, the things that you're invested in are different than on the days where you have tremendous energy and optimism, right? So the content of the personal picture album is incessantly changeable. It's unique to the individual, unique to circumstances, that sort of thing. And here's the important thing. It can be in what he calls internal conflict, meaning you can have things that you value in that personal picture album that are mutually exclusive. You can't have both of them. So you can develop, part of what brings people into psychotherapy is conflict between things that they value. A person who wants very, very much to be in a long-term committed relationship, but at the same time is hesitant to fully invest themselves because they can't shake the worry that, well, maybe what if there's somebody else better for me out there, right? So they have these parts of their personal picture album, these aspects of their quality world that they've invested considerable energy in that are mutually exclusive. And then, of course, these items in the personal picture album can vary in intensity and in terms of how attainable they actually are. Realistically, how likely is it that you will actually get these things that you have invested energy in? Okay, so we have the perceived world, which is essentially the world in our subjective experience, the way we perceive the world to be, however accurately or inaccurately. And we have the quality world, which is essentially what we're emotionally invested in our worlds, what we would like things to be like, what we would like the world to be, what we want out of the world. And then Glasser makes the point that we have, that he identifies what he calls the comparing place, which is not actually a place, it's a process. And it's the process or it's the experience of tension, maybe is a better way of putting this, between the quality world and the perceived world. The tension that arises between this is how I experience the world as being, perceive it as being, and this is what I want it to be. And he basically makes the point that to the degree that there's some inconsistency there, to the degree that the quality world, the way we want the world to be, is incongruent with the perceived world, the way we perceive the world to be, serves to motivate us to behave, to take some action, to bring the perceived world into some greater degree of congruence with the quality world. Put it slightly a different way, it motivates us, it energizes us, the comparing place does, energizes us to take action so that we can institute change in the perceived world and our subjective experience of the world, so that it falls more in line with what we want, with how we want things to be. And then the last of these four important concepts on which reality therapy is based is Glasser's assertion of what he calls total behavior. And this is basically him saying all behavior is purposeful. And we can nitpick that, but he has a good argument, generally speaking. Certainly most of what we deal with in psychotherapy is purposeful behavior, is behavior that the person has chosen, for better or worse, intentionally. Now, the intentional choice may not be fully conscious. You may not know all the reasons why you've chosen something, but the vast preponderance of our behavior we have chosen. And he's basically making the point that how you behave is your best attempt, given your environment, given the resources that you have available to you, to get the quality world to match up with the perceived world, essentially to get your needs met. He makes the point that we rely on what he calls organizing behaviors, which are basically things, I've done these things in the past and they worked for me. They got my needs met. They were to some degree successful in fostering some degree of congruence between the perceived world and my quality world, my personal picture album. And when you run into a situation in which organizing behaviors, previously practiced behaviors that were effective, become frustrated, things that they no longer work, he calls this, if you make a change, then if you okay, so this tack didn't work, it didn't get my needs met, so I'm going to try something different this time. Glasser calls that reorganizing behaviors, which is really what we're pursuing in psychotherapy, is that we're wanting to foster in the patient or the client some creative and imaginative sense of how I can go about things differently. What I've been doing to this point has not gotten my needs met. How can I go about it in a different way that may be more successful? So substituting reorganizing behaviors for organizing behaviors that are no longer successful. So Glasser specifies that these organizing and reorganizing behaviors, he basically breaks them down and points out the obvious. I think this is quite easily demonstrated that these organizing and reorganizing behaviors are comprised essentially of four components. Behavioral action, the actual behavior itself, the cognition or the thought underlying it, the emotional experience underlying it, and the physiology underlying it. He makes the point that we have relatively limited capacity for control, and we've talked about this before in class, that emotions by and large are things that happen to us rather than things that we choose. We can undertake practices to exert better control over our behavior and our thoughts, and by doing that, begin to have some influence over our emotions. If you change your behavior, if you change the way you think about the world, you are going to likely have some influence, positively or negatively, over how you feel about the world. But it's a very difficult thing to directly exert energy and cause yourself to feel differently. You can't, by force of will, change your emotion. To a slightly greater degree, we can control some, to some degree, we can control our physiology. This is part of what things like relaxation, breathing, and meditation, and so on and so forth are about. This is what exercise is about. This is what sleep is about. Sleep hygiene, good healthy sleep practices. The idea that if we can do some things to manage how we're reacting physically to a circumstance. We have something makes you angry. It's a very difficult thing to close your eyes and say, I'm not going to be angry anymore. Very, very difficult thing to control the anger itself. We can focus on the physiology of anger, and we can do some things to try to kind of settle down that autonomic arousal. I can slow down my breathing. I can consciously, clench and relax the muscles in my neck and my back and my hands. Shake out your arms and things. Trying to reduce the muscle tension, try to control the breathing. As you control the breathing, that brings the heart rate down, that brings the blood pressure down, et cetera, right? So we can develop some degree of control over physiology. But if you're thinking to yourself, well, you're not really controlling your physiology, you're controlling your behavior. You're practicing certain behaviors, breathing, physical movements to relax the muscles, and you'd be right on track if you were making that point. And that's what Glasser is saying. He's saying, that physiology, we have a limited degree of control we can exert over it. We have a very limited degree of control that we can exert over our emotional experience. We can, however, exert a fairly significant degree of control over the behaviors that we choose or don't choose. So we have some control. We have a fairly significant degree, perhaps the greatest degree of control over our action, and to a slightly lesser degree, we have control over thought, which we've already talked about last time when we talked in terms of cognitive behavior therapy. So reality therapy is technically a cognitive behavior therapy, so it's a subset of cognitive behavior therapy, because it's focusing on behavior and cognition, action and thought. So this, what I've been describing so far is what Glasser called choice theory. And the problem that he's laying out is that this choice theory, the organizing and reorganizing efforts to bring our quality world in line with our perceived world, is not always successful. And he developed reality therapy as a problem-solving method based on the choice theory, to help people get better control over the action and thought, the behavior and cognition that shapes their lives. So we use this reality therapy, as I've already kind of mentioned. We talk about, we take this reality therapy approach most frequently in parenting education, educational settings, IEPs, that sort of thing. We can use it like in human resources settings to foster improved leadership ability and management ability. Essentially, what we're doing in the reality therapy process, if we were to really boil it down to the simplest components, is that we're asking people what they really want. We're helping them figure out, what do you actually want? Not what you tell yourself kind of in the heat of passion that you actually want. What do you, when you weigh your options, when you weigh what's available and not available, what do you actually want out of life, out of your world? And what are you doing to get it? The guy, the psychologist, the Oprah Winfrey psychologist, I cannot think of that guy's name. Not Dr. Oz, Dr. Can't think of his name. The Oprah Winfrey psychologist. You probably have seen this guy before. I find him annoying, but he has made a good career essentially out of using reality therapy. The one way that you probably know Dr. Phil, that's his name, Dr. Phil. The way you know Dr. Phil, the catchphrase that you probably know Dr. Phil by would be, "How's that working for you?" And that's actually that's something he gets from reality therapy. That is essentially what reality therapy is asking people. We sat down, we figured this out. We know you want this. This is what you have been doing to get what you want. How is that working for you? And the reality therapy is kind of methodically walking them through how well is that, are the strategies you've been using so far working to get you what you want. And generally, of course, if somebody's coming into you for psychotherapy, the conclusion they're going to come to is it's not. These things are not getting me where I want to be. These choices that I'm making, these behaviors, and the way I'm looking at the world, thinking about the world, is not getting me what I want. And that, helping the person get to that conclusion and admit that to you, and more importantly to themselves, is the mechanism by which we go, okay, what can we do differently now? How can we help you get to take different action, to take a different approach to what you're doing? And you can see how this works well for people who say maybe have gotten in trouble with the law, students who are their lives are a mess because they're failing out of school and their parents are pissed off at them and the friends don't like them and all that kind of. You're making these choices. This is the outcome of these choices. This is not what you want. This is what you want. How do we get you from where you are now to where you want to be? So Glasser builds his reality therapy around 10 axioms. We're going to talk about only 9 of them. I'm not going to spend much time talking about the 10th one simply because it's not all that necessary in order to get a good handle on reality therapy, and we're limited in time here. But the approach to reality therapy, the approach to actually helping somebody with this cognitive behavioral technique, starts with helping the person recognize that the only behavior you can control is your own. You don't get to decide how the people around you behave. You don't get to decide, for that matter, although this isn't necessarily part of the axiom, you don't get to decide how the people around you feel. All you can do is give them information. Axiom 2. That all you can do is lay out for them as accurately and in a healthy way, assertively as possible, information. This information would include things like your own thinking, your perspective on things, your expectations, your hopes, these kinds of things. Beyond that, you don't get to decide how another person behaves, or for that matter, how another person thinks or feels. You can provide information, and that's where it stops. These 2 first axioms, the only behavior we can control is our own, and all we can do is give other people information, is important because Glasser is going to ask the person to focus on relationships as the likely source of whatever psychological problems are bringing the person in for psychotherapy. So he's essentially saying you might be bringing in things that are not on their face necessarily relational, but that if you dig down deep enough into what's really going on, the odds are, in fact, that they do arise from some sort of problem in a relationship that can be addressed in part by the first 2 axioms, accepting that all we can control is our own behavior, and that all we can do is give another person information. So, for example, you might have somebody, and you might have a student coming in for psychotherapy, in part because they're having problems with procrastination, inadequate academic performance, not attending class, these kinds of things. Things that are not manifestly relationship based, but what you generally find, and Glasser I think is right in this regard, what you generally find is that those kinds of behaviors ultimately at their core do often, perhaps inevitably, come down to relationship. That say a student is getting B's and A's, and when you begin to look at it and you get to know who they are and you talk to the professors and so on and so forth, the feedback you're getting from people is, well, actually this is fairly consistent with this person's potential. This person is an A and B student, a A minus, B plus, B level student. But the student is distressed because he or she feels like they're underperforming. And generally when you get that situation arises more frequently than you might imagine. When you begin to explore that, what you discover is that the person is struggling under the burden of expectations that perhaps now are their own, but did not originate as their own, often are handed down by parents. Conversely, sometimes you get somebody, similar situation, where they come in because there's some degree of underperformance, but in this case, the underperformance is actually objectively pretty real. They're in danger of failing out because they're not attending class, and when you begin to kind of peel back the layers, what you come to recognize is that there is some degree of self-sabotage, and that ultimately the self-sabotage comes down to not infrequently relationship with authority figures, parents or whoever else, and that it's some expression of hostility, resentment. The self-sabotage is revenge-based, that I'll get back at my parents by screwing this up royally, these kinds of things. So as much as it may not be apparent on the face of it, Glasser's assertion that all long-lasting psychological problems are relationship problems is a pretty solid assertion. And he makes the point then, he's working to get acceptance from the patient that the only person whose behavior you can control is your own. All you can do is give other people information. All long-lasting problems, psychological problems, are fundamentally relational in nature. And whatever the problem relationship is, it remains part of our present life. So this can be manifestly obvious in the case of our student who is having some sort of trouble with whoever the authority figures are in his or her life. Mom and dad's expectations are too high. There's some resentment and hostility in the relationship between the student and the parents, and those are cases where the relationship in the present tense is very apparent. It's very obvious. But you also have circumstances where it isn't so apparent isn't so obvious how the relationship remains part of our present life. And I'll give you an example of that. The same basic setting, that the student is struggling with performance, and that when you begin to explore, they're procrastinating terribly. And that when you begin to explore this with the patient, it becomes apparent that the procrastination has at its core a fear of failure, and the fear of failure is related to a reluctance to disappoint the idealized parent, and you find out that the idealized parent is in fact deceased, which would seem to make the relationship not part of your present life, but in fact the reality that the student, and this is not an uncommon sort of a dynamic, remains afraid of disappointing somebody who's no longer present, has made the relationship part of your present life. And the reality is, if you've ever lost somebody important to you, your relationship with them, despite the fact that they're gone, continues. It may not be it may no longer be a physical relationship that is developing mutually. In other words, the other person is no longer there to interact with you. But just because the other person is gone does not mean the relationship stops. And if you are bridling at that, if you're kind of arguing with that in your head, the odds are you haven't actually lost somebody important to you. I'm not saying that you haven't, but most people who have lost somebody important to them resonate very readily with the reality that I know I still do remain in relationship with them, even if they're not here. In the sense that they remain an influence in your life. And that kind of gets to axiom number 5. What happened in the past has everything to do with who we are today, but we can only satisfy our basic needs right now and continue satisfying them in the future. So basically what Glasser is asking the person to accept is that we certainly are impacted by our past, by what's happened in our relationships previously. But one, how we respond to think about, feel about these relationships, these past events, maintains them in the present. And that to the degree that we respond to them in these ways in the present, to the degree that we, say, for example, in the example I was just giving you of the person who is procrastinating because they're preoccupied with worry about disappointing the idealized late parent, the deceased parent. That the prior relationship, the childhood relationship with that idealized parent, may be very important. It may do a lot to explain how the person got to where they are today. But Glasser is essentially kind of asking them, let's move into the present now. All we can do to get our needs met is behave in the present. And so the effort here is to bring the person's attention, emotional investment, cognition into the here and now, and look at what can we begin to do now. He then makes the point that kind of goes hand in hand with all this, that we can only satisfy our needs by satisfying the pictures in our quality world. In other words, we have an image in our head about the way the world should be, the way that we want the world to be. We have a certain degree of investment in certain expectations, desires. Again, that quality world, the things that we have cathected, the things that have become important to us. And this becomes important because it puts you in the position of, okay, do we actually pursue the behavior change necessary to get that particular need met the way we're picturing it, or do we change the picture? Do we change the quality world? Do we begin to work to change our thinking about what do we really want? What is it that is really important to us? And then he makes the point that in terms of that total behavior idea, that all we do is behave. And basically what he's wanting to do is he's wanting to get a good degree of investment in the idea that how we act in the world has a profound effect on our path. I could not possibly overstate the importance of this idea in psychotherapy. I know I've run this into the ground, but I'm going to say it again. if you can get somebody motivated, committed to changing fairly basic behavior, accepting responsibility for and implementing change in basics like sleep, exercise, and diet, that alone, making sure that their nutritional needs are met through supplementation if necessary, good, healthy, balanced diet, vigorous daily exercise, and protecting and promoting good sleep. That alone, in the vast majority of cases, is going to buy fairly significant improvement in a person's psychological status. Emotionally, they're going to feel better, they're going to think better, they're going to perform better. So he's making the point, when he makes the point that all we do is behave, he's wanting to kind of focus the person's attention, the patient's attention, on the idea that the central importance of action. Related to this, he's making the point in Axiom 8, all behavior is total behavior and is made up of 4 components: acting, thinking, feeling, and physiology. So he's basically, he's doing that cognitive behavioral delineation between thinking, feeling, emotion, and of course the underlying factor of physiology. And then in Axiom 9, he is emphasizing to the person that you need to begin to accept the limited degree of influence that you have, direct influence that you have over your emotional state and your physiological state. And instead, and this becomes important, of course, when you have somebody coming in struggling with guilt over, a not uncommon one is that they feel some significant hostility, hatred even, toward somebody that they love, that ambivalence, right? Not an uncommon sort of a thing, and that often is accompanied by pretty profound guilt. And what Glasser would have you focus on is that you have limited control over how you feel. The intensity of the hostile emotion that you feel in this relationship you have a limited capacity to do anything about that. What you can do something about is how you think about and how you behave about this person. I'll give you, I think I may have said this to you before. I'll give you an example of this. I think I've talked in here before about the fact that I'm a religious Catholic, and part of being a religious Catholic is you go to confession. It's not optional. And I went to confession. This is a couple of years ago now. I went to confession, and part of the confession was a tremendous degree of hostility, frankly, a fairly unreasonable hostility that I feel toward this one individual person who happens also to go to my church. I struggled with it for a long time, still struggle with it to this day. But the circumstances were improved by the priest. One of the things, when you go to confession, you confess your sins. You're honest with the priest about the things that you understand as unacceptable. And then the priest recommends to you or orders to you penance, something you can do to either to make up for what you've done wrong or to demonstrate your genuine penitent position. You're genuinely sorry. And then you're granted forgiveness. Well, in this case, what the priest recommended to me, I guess ordered to me, me to do, was to pray daily for this person toward whom I felt so hostilely. So what he was saying to me, in Glasser's terms, is I want you to take charge of the thinking. You can't necessarily do anything about how you feel about this person. Take charge of the thinking about this person. And I want you to spend time thinking in this case, praying, which is both thinking and behaving, right? You know, that you're intentionally, you know, in the traditional sense, you know, down your hands on your knees, hands clasped, having a conversation with God, and he's saying, you know, I want you to pray for this person's welfare. I want you to spend time thinking about how you want things to be okay for this person, that you want this person to be helped, to have their circumstances improved. So good example. With this, I don't think the priest necessarily had a course in reality therapy, but even outside the religious, you can use a similar approach with the secular. If somebody is struggling with that kind of hostility towards somebody in their life, one of the things you can do in the course of reality therapy, perhaps, if the hostility is ego dystonic, if the person is uncomfortable with the degree of the hostility that they're feeling, one of the things that a reality therapist might talk to them about is, okay, I want you to go out of your way, maybe at first, anonymously, to do kind things for this person toward whom you feel hostile. And you know, perhaps the reality therapist might suggest that you spend a specific amount of time, maybe that you do some homework documenting in a journal positive attributes about this person. You know, so you can't control how you feel. You can control how you behave, and you can control to a fairly significant degree how you think, what the cognition is. So that number 9 axiom, that we have only direct control over acting and thinking. So really focusing on the idea that we're going to elicit change emotionally, basic cognitive behavioral therapy, by emphasizing the degree to which we can control what we do and how we think about the world around us, how we think about ourselves, how we think about our behavior, how we think about our emotions. And like I said, I'm going to skip out on number 10 simply because it's not absolutely necessary and I'm limited in time. I was going to try to get this done within an hour. Let's see. And last few things for reality therapy, kind of laying the groundwork for effective reality therapy. And I'd say to some degree, this stuff is fairly universal for therapy, but absolutely necessary for reality therapy. You want a good commitment from the patient to accept responsibility for themselves and to work hard at the things that you're recommending that they work hard. So you want them to like you. You want to be friendly, fairly energetic, and I don't mean frenetic. I mean just you want to be clearly invested in them, clearly a cheerleader for their welfare, but warm, friendly, supportive, that sort of thing. You want to be very, very clear about what your role is as the therapist, what the patient's role is. That's part of where the axioms come in. Being very, very clear with them that they are responsible for making behavioral changes. They are responsible for completing homework, that sort of thing. We want to, this is part of where the choice theory stuff comes in. Glasser emphasizes the idea that you want to be really cognizant of supplying what he calls a needs satisfying environment. Obviously, you want the office setting, the physical setting of the psychotherapy to be physically safe, emotionally safe, comforting, secure. In other words, it matters what your office looks like. You know, you want it to be a place that the person feels comfortable, maybe even looks forward to coming. I don't know this definitively, but I would suspect, while some psychoanalytic psychotherapists might bicker with the idea of offering tea or coffee or a snack to a patient, I suspect that Glasser would be a little less worried about that. You know, that he would want to be seen as nurturing and warm and friendly to the patient. And obviously part of doing good psychotherapy is fostering a sense of connectedness, of empathy, that sort of thing with the patient. You're really making a concerted effort to reinforce what you perceive and what the patient perceives as his or her strengths and skills. You know, we're here to deal with some of the problem areas. We're here to deal with the areas of weakness. But one of the best ways of doing that is to lean on the things that you're good at, and to continue to build the things that you're good at. The other thing that we're wanting to make sure we do as a reality therapist is really emphasize to the patient their responsibility for their own behavior, their responsibility for their thinking, that ultimately the choices they make cannot be blamed on anybody else. So other people's behavior is not an excuse for your own behavior. Other people's behavior is not an excuse for your own thinking. And then, of course, the other piece of it is there's no reason why there shouldn't be laughter and affection in the psychotherapy. He would emphasize, that having a good sense of humor, trying to make things as enjoyable as possible is a very reasonable thing, and you're going to get a whole lot better buy-in. It's one of the things that gets often missed in psychotherapy is people see it as so, and it's understandable that you would see it as profoundly serious because people are coming in often in a lot of pain. But the reality is one of the surest ways of coping with significant pain is humor. Finding ways to have fun. If nothing else, it's a relief from the pain. The reality therapists, and this is part of the emphasizing a person's autonomy, that they are responsible for themselves. The therapist is not responsible for you. I'm not going to cure you. You're going to fix yourself. You're going to fix your own behaviors. I'm going to do what I can to help you, but you're the one who fixes it. Kind of along those lines, the therapist is working to help the patient become less tolerant of their own excuse making, to begin to become less tolerant of self-damaging behavior, emphasizing full acceptance of responsibility for one's choices. And partly related to that, one of the other things the reality therapist is going to do is going to, whenever the focus shifts into the past, and this happens a lot with people in psychotherapy because they're bringing in part of the burden that they're struggling with is, resentment and regret and these kinds of things having to do with their historical lives, their upbringing, wrongs suffered at the hands of friends, significant others, parents, these kinds of things. While we're not making that off limits in the reality therapy, what the reality therapist is going to do is okay, you kind of let the person have their say, and then you bring them back to the present. How is this being expressed now? How is it affecting you now? And of course, the other thing we're doing is we're using what's happened in the past. This is a matter of perspective taking. People will sometimes come in and they will talk about bad things that have happened to them in the past. And part of reality therapy might be looking at, acknowledging that it was a painful experience, and then looking at, are there any positive consequences today of that painful experience? Did it build you in some way, even though it hurt you? Some cases that isn't the case. Sometimes there isn't anything positive that comes from a bad circumstance. Most of the time, though, there is a silver lining. There is a positive impact. And in fact, you can even make the argument that part of psychotherapy is helping the person identify or develop positives from negative events. If they've been traumatized in some way, trying to identify or trying to develop ways in which that trauma ends up having a positive effect in their lives, in the patient's life. good basic psychotherapy. It isn't your job as a psychotherapist to punish the patient or to criticize the patient. What we're wanting to do is foster in the patient a fair and just internal voice. An internal voice, so you're not the one doing it. It's not the parent in the transference doing it. That they have internalized and accepted their own voice, holding themselves responsible for their behavior, solely responsible for their behavior, holding themselves responsible for effort in directing their cognition. Resisting the urge to be that parental criticizing voice. Most patients have got that in spades and don't need that. What they need is help moderating their own internal voice. But then the flip side of that coin is also a parental mistake. We have to avoid trying to protect the patient from reasonable consequences of their behavior, of their choices. And this would include objective, practical protection. That we're not going to intervene in ways. You're working with an adolescent patient, and they go out and they get alcohol, and they get in trouble, caught, and now they're grounded by their parents. And the kid might ask the therapist to intervene and reduce the punishment, which actually, in fact, might be significant, might be perhaps even a little more punitive than the therapist sees as reasonable or as optimal. But as long as the punishment isn't outlandish, it isn't abusive, what the therapist is going to do is help the patient, in this case the adolescent, accept responsibility for their behavior and try to find a way to elicit whatever change it is that they desire. And sometimes you can't elicit that change. The other thing that in terms of protecting the patient from reasonable consequences, or the avoidance of the urge to protect the patient from reasonable consequences, would be not giving in to the urge to let the patient off the hook, to get not giving into the urge to help the patient let themselves off the hook inappropriately. If the patient has done something wrong, unjust, and they feel guilty, well, guess what? They should feel guilty. You do something bad and you feel guilt about it, that guilt is healthy. And it can be a difficult thing sometimes, especially if you have true affection for your patient, to resist the urge to provide for them some absolution, some relief from their guilt. The only appropriate relief from the guilt is when you make amends or you seek forgiveness and are granted it. So avoidance of punishment, criticism, and protection from reasonable consequences of their behavior. And then the last point that he makes in terms of establishing a good, productive environment for reality therapy is being very cognizant of not being overwhelmed. This is a really common experience for therapists, myself included. Sometimes people come in and it is just the storm that their lives is just boggling, and you almost don't know where to start sometimes. Glasser would remind the therapist that in the spirit of choice theory, you are not responsible for other people's circumstances. You're not responsible for their behavior. You're not responsible for their choices. You're responsible for your own. The patient is responsible for his or her life. You are responsible for helping them help themselves. You can't do everything at once. So you work together to find out what the heaviest burden is, and if it's something that's reasonably changed, you have to kind of weigh your options here. What you're really looking for is something that has a fairly significant impact on their lives that can be reasonably changed relatively quickly. That's one of the reasons why I always say sleep, diet, exercise is fairly easy to fix, fairly easy to at least, if not fix, at least get some improvement in, and thus build some momentum. The reality is that you're going to have patients whose lives cannot be completely fixed. In fact, most people's lives can't be completely fixed. You're going to have some patients whose lives are in such disarray that you're going to have to pick and choose your battles. This reminder from Glasser is actually a very useful one in psychotherapy. Okay, and the last thing that we'll talk about in regard to reality therapy is just kind of a summary of the procedures that reality therapy understands as leading, as producing the change in psychotherapy. And none of this should be a surprise at this point, except for maybe the last. One of the last items there, the acronym that you'll see in the third to last bullet point. But prior to that, all these things should be easily recognizable now that we've talked about choice theory and reality therapy. First, getting a buy-in from the patient that everything you do, you've chosen. Everything. It may not be obvious why you've chosen these things, and we may need to explore that and kind of talk through it so that you understand why you've made this choice as opposed to other alternative choices. But all behavior, even painful, dysfunctional behavior, is chosen. And then we want to sit down with the person and look at what is it that you want? What is this behavior an attempt to elicit? You're behaving in a certain way. You've chosen behaviors to try to get something that you want reflected in the quality world. And so what we're really asking the person to do is think very carefully, methodically, and to identify what in the quality world, what is the picture that you have for yourself. And then looking at, it's that Dr. Phil thing. How is that working for you? What are you currently doing to get what you want? And generally, this is the problem behavior that is part of what brings a person into psychotherapy. So what are you doing? Is it actually helping you? Is it helping you presently? Is it anticipated that it's going to help you? And if not, are you willing to consider alternatives? Are you willing to begin to look at alternative behaviors? And generally that's, if you're reasonably good as a salesman, and that's part of being a good psychotherapist, is helping to sell the patient on the possibility that things can be different for him or her. If you're relatively good at that, these first 5 bullet points here under procedures that lead to change, this is it's a process, and it may take several sessions to kind of get to the kind of the last bullet point before you actually begin to implement some different path. Would you like to try something different? When you get the buy-in from the person, and you emphasize to them, it's not necessarily going to be easy. It may take a little while. You've been doing it this way, whatever the dysfunctional way is. You've been doing it this way for a while. Let's try something different. And when you get the buy-in, you methodically and concretely make a plan. And Glasser uses the acronym SAMIC3. The plan needs to be simple, attainable, measurable, immediate, consistent, client-centered, and it can be something that the client can commit to. So consistent, client-centered, and committed to is the C3. It has to be simple. It has to be something that the patient can hold in mind and easily recount. You want it to be realistic. You want it to be something that the person can actually accomplish, as opposed to some distant pie in the sky sort of a thing. And you may have an eventual long-term pie in the sky kind of goal, but the immediate plan is comprised of much shorter term, attainable, measurable goals, because you want to be able to know objectively, did I accomplish what I was seeking? And measurable, we're talking about behavior change fundamentally. So measurable and immediate, what we're talking about, measurable, immediate, and attainable, we're talking about short-term practical goals that a person actually has some degree of success with. And again, when you're doing psychotherapy, you want to build on success. You want to establish, especially early on, goals that you're fairly confident the patient can attain. Goals that the patient feels confident that they can attain. You want to get them with some momentum of going from success to success and building toward the more challenging goals once you have that momentum. Yeah, and then obviously consistent, client-centered, and something that they can commit to. You want it to be something, by and large, you want the plan to be something that maybe you help them structure, but they really do feel like they kind of came up with it. It's a step-by-step process that they helped formulate, or largely formulated, perhaps with a little bit of assistance from you, to get them to where they want to be, not where mom and dad want them to be, not where their significant other wants them to be, not where you want them to be, where they want to be. So that's the client-centered part. You're going to get a whole lot more buy-in when the person is working on something that they feel like is their choice. And it needs to be something that they feel like they can commit to, and then you very concretely elicit that commitment. And perhaps what you know, not infrequently in reality therapy, you actually write this stuff up, and perhaps the final step might be the patient signing that they are committed to making these changes. That, you know, and they're coming through with homework. This is part of the following up. They're doing homework. They are implementing stepwise change. They're doing this. Okay, now that we've accomplished this, this is the next goal. Okay, now that we've accomplished this, this is the next goal. We're continually following up, reinforcing their commitment, praising the successes that they have, problem solving the points where they're not having success, looking at alternatives. If we set a goal and they're just not hitting that goal, okay, let's break this down a little bit further. Let's see if we can make it into sub goals that can be accomplished. This sort of thing. The reality therapy stuff is nice, especially if you're kind of a pragmatic person who likes problem solving. If you're fairly charismatic and high energy, it tends to work better for you. And if you see yourself working with people who perhaps are struggling to some degree with motivation, it tends to be a pretty good fit. So I'm going to cut it short here. I was aiming for an hour, and it looks like we're at about an hour and 10 minutes. I'll go ahead and close here.